Okay, let's unpack this. Trauma. It's the leading cause of death for people under the age of 44. I mean, think about that for a second. That's huge.
It really is. And a critical, often life or death piece of that whole picture. Injuries to blood vessels, what we call vascular trauma.
Yeah, absolutely critical. When someone suffers, severe trauma, an accident, violence, whatever it is.
Damage to arteries and veins is often the most immediate threat. Stopping the bleeding, getting blood flow back where it needs to go, that's paramount.
And that's exactly the complex, really vital topic we're diving into today. You've shared some detailed source material with us, basically an expert text on vascular trauma.
Right. And our job here is kind of act as your guides, sift through this dense material, pull out the essential insights for you.
We want to help you understand the core of vascular injuries, how they happen, the really critical signs doctors and nurses look for.
Exactly. How they're managed and what challenges can come up afterwards.
Think of it as your shortcut to being genuinely well-informed on this pretty important area of medicine, all based on the source material you provided.
So let's start with the big picture. The source confirms that stark statistic you mentioned, trauma, leading cause of death for younger people.
It's not just about broken bones or organ damage, is it?
No, not at all. It powerfully underscores just how lethal vascular injury can be.
And what's really interesting, according to the text, is that the types of vascular injuries we see today, they're changing compared to, say, wartime data.
That's right. Less extremity trauma now, apparently, and more injuries to the neck and the trunk.
That's a significant shift.
It is. Plus, the source highlights an increase in vascular injuries from some specific modern causes. One is self-injection by intravenous drug users,
Okay.
and the other is complications from procedures done inside blood vessels. Endovascular procedures, they're called, things that just weren't as common decades ago.
Okay, so the landscape is definitely evolving. Now, let's get into how these injuries actually happen, because the source makes it really clear that understanding the mechanism is key to managing them.
Right. The material breaks it down pretty well. The most common type, penetrating trauma, that's when an object pierces the skin and tissue.
Like gunshots, the source says over half, and knife wounds, which are also a major cause.
Exactly. And the difference between those, well, it can be vast. A knife, or say a low-velocity bullet, it tends to cause more localized damage right along its path.
That could contain damage.
But a high-velocity missile, it creates this incredible, almost explosive cavitation effect. The source notes it can be 30 to 40 times the size of the missile itself.
Whoa. 30 to 40 times.
Yeah, so that means extensive, just devastating damage to vessels and all the surrounding tissue, way beyond the direct wound track.
Then it really changes the scale of destruction, doesn't it? And the source also points out that even medical procedures can cause penetrating vascular injuries.
Yes, like when intentional access, maybe for one of those interventional procedures we mentioned, goes wrong. That's called iatrogenic injury.
Which brings us to the other big category, blunt trauma. This is injury without an open wound.
Right. Think motor vehicle accidents, falls, serious assaults, even some sports injuries.
So here, vessels aren't cut open from the outside.
No, but they could be crushed or stretched or even torn by the forces involved, like from broken bone fragments or a joint dislocation, putting tension on an artery.
Okay.
And a really critical point from the source is that blunt vascular injuries often have a more serious outcome than penetrating ones.
Wait, why would a closed injury be worse than an open one? That seems counterintuitive.
Well, because they're just much harder to spot initially. The damage isn't obvious from the outside, right?
Oh, okay.
And the source notes this can lead to delayed diagnosis, which is dangerous. It can actually be a hidden cause of death sometimes.
Hidden and dangerous. Got it. The text also briefly mentions blast injuries from explosions.
Yeah, often military or industrial, but sometimes things like fireworks too. They can cause a mix of penetrating and blunt trauma effects.
Okay, so that covers the main ways these injuries happen. Now, who is typically affected? The source lists some risk factors.
It does. Things like age, gender, alcohol or drug use, involvement in violence.
And this connects to what the text says about injury across the lifespan. It points out most trauma patients are, well, young and male.
Right. And these injuries are often sudden, and unfortunately sometimes linked to drug or alcohol abuse.
But it contrasts that with those iatrogenic injuries, the ones from medical procedure.
Exactly. Those are more often seen in older patients, perhaps because they're undergoing more procedures for age-related conditions like heart disease or peripheral artery disease.
And regardless of how it happens or who it happens to, any existing health problems, they really impact recovery chances, don't they?
Oh, absolutely. Comorbidities significantly affect outcomes, no question.
Speaking of those iatrogenic injuries, since the source highlighted they're increasing, let's spend a moment there. Why the increase, and where do they usually happen?
Well, the increase seems tied to just doing more procedures inside the vessels, interventional radiology, cardiology procedures, things like angiograms,
Makes sense. More procedures, more potential complications.
precisely. And the most common sites are where doctors typically gain access. The femoral artery in the groin is a big one, and the brachial artery in the arm.
And the text lists several specific problems that can happen during these procedures.
Yeah, quite a few.
Right.
Things like a hematoma, which is a collection of blood outside the vessel, or just uncontrolled bleeding, hemorrhage.
Okay.
You can get an abnormal connection between an artery and vein that's an arteriovenous fistula, or the artery can get blocked off, causing acute limb ischemia, lack of blood flow.
Scary stuff.
Also, clots can form and travel downstream, blocking smaller vessels, or you can even get pressure on nearby nerves from swelling or bleeding.
And are some people more at risk for these iatrogenic injuries?
Yes. The source mentions a few factors. Difficulty applying pressure to the access site, maybe in patients with obesity. Advanced age itself is a factor.
Okay.
Also, having severe existing vessel disease, like atherosclerosis, being on blood thinners, anticoagulants, or even having had procedures done in that same spot before.
Okay, so we know the how and the who. The next crucial step is actually finding the injury. The source really emphasizes that the primary goal in any trauma assessment is always just patient survival.
Always. First things first. Initial priorities are the ABCs, right? Airway, breathing, circulation. Supporting circulation with fluids, stopping any major bleeding you can actually see.
And understanding how the injury happened helps guide your search for specific damage.
Absolutely. Then comes the physical exam. You're looking for entry or exit wounds, swelling, obvious bleeding. But the source introduces a really critical concept here for vascular injuries, the difference between hard signs and soft signs.
Okay, hard versus soft signs. Tell us about that.
This is fundamental. Hard signs are the unmistakable indicators. If you see these, a major vascular injury is very, very likely present.
Like what specifically?
Like bleeding that's actually pulsing with the heartbeat,
Yeah.
or a vibration you can feel over the vessel that's called a thrill, a hematoma, that collection of blood that you can literally see getting bigger, expanding,
Wow.
or hearing a continuous whooshing sound, a murmur with a stethoscope over the injury site. Those are big red flags.
Okay, those sound pretty definite.
And the source points to that classic list often taught in medicine, the 6 Ps. These point towards acute limb ischemia, a lack of blood flow.
The 6P. Okay, what are they?
Pain usually severe, out of proportion. Pallor of the limb looks pale, white. Pulselessness, you can't feel a pulse below the injury. Paresthesia, that's numbness or tingling. Paralysis, the inability to move the limb. And poikilothermia, the limb feels cold compared to the rest of the body.
Pain, pallor, pulselessness, paresthesia, paralysis, poikilothermia. Got it. Those 6Ps really paint a clear picture of a limb in serious trouble.
Absolutely. Yeah. If you see those hard signs, or the 6 Ps, it strongly suggests a major arterial problem.
So hard signs mean likely major damage. What about the soft signs then?
Soft signs are less definitive, but they still raise suspicion, make you investigate further. Maybe the patient had significant bleeding or shock initially, but it's controlled now.
Okay.
Or a penetrating wound that's just very close to where, major vessels run, even if you don't see hard signs right away. A hematoma that's there, but small and not expanding.
Uh-huh.
A nearby broken bone or dislocated joint that could have injured the vessel. Any new nerve problem in the limb, like weakness or numbness, or even just finding a weaker pulse in the injured limb compared to the uninjured side.
Okay, so hard signs scream vascular injury. Soft signs kind of whisper, be very suspicious.
That's a good way to put it.
Yeah.
And crucially, according to the source, the presence of hard signs often means that patient needs to go directly to the operating room. Like now, no delay.
Wow. Okay. Immediate surgery.
Speed is absolutely critical with these injuries, especially arterial ones. It's about saving the limb, or sometimes saving the patient's life.
So what happens if there are only soft signs, or if the injury is complex or maybe not obvious?
That's where diagnostic testing becomes essential. You need to confirm if there is an injury and figure out exactly what needs to be done.
The source lists lab tests first. Standard blood work.
Yeah, checking for blood loss with a CBC, getting blood type and cross-match ready in case they need a transfusion, checking electrolytes, kidney function, clotting ability, the basics.
And also tests maybe looking for contributing factors.
Right, like blood alcohol level, toxicology screen for drugs, sometimes tests like amylase or CK depending on the suspected injuries. These give a picture of the patient's overall status and help prepare for what might come next.
Okay, labs paint the general picture. Then there's imaging.
Correct. Non-invasive tests often come first. Things like advanced ultrasound, duplex ultrasound is great for looking at blood flow, checking for things like pseudoaneurysms or DVTs maybe later on. Chest X-ray can show bleeding in the chest, a widened mediastinum suggesting great vessel injury. CT scans are used a lot to look for bleeding inside the body, fractures, that sort of thing. MRI can be useful too sometimes.
And then there's imaging specifically designed to visualize the blood vessels themselves.
Exactly. That's where things like CT angiography, CTA, or MR angiography, MRA, come in. These give detailed pictures of the arteries and veins.
And the source mentions traditional angiography too, where they inject dye directly.
Yes, arteriography still has its place. The source suggests it's often used in specific complex cases. Maybe a stable patient with multiple injuries where you need a roadmap, or extensive soft tissue damage, certain types of shotgun wounds.
Okay.
Or if you suspect injury to vessels that are hard to see otherwise, like up near the shoulder, the subclavian or axillary arteries. Or if the patient has known pre-existing vascular disease, it really helps plan the repair.
So imaging confirms the injury and guides the fix. Let's talk about that fix the management. The source highlights that this is complicated, depends entirely on the type of injury and where it is.
Yeah, it's definitely not one size fits all. Medical management alone, meaning without surgery, is pretty limited for major vascular trauma.
Mostly just keeping the patient stable.
Pretty much. Fluid resuscitation, maybe vasopressors medications to support blood pressure. The source mentions some temporary measures you can do through catheters, like using a balloon to block bleeding, or placing a covered stent in some acute situations. But it also emphasizes that trying to manage major vascular trauma non-surgically is still quite controversial.
So usually surgery is going to be necessary.
Often, yes.
Yeah.
Especially for significant arterial injuries.
Let's run through the different locations the text covers. Extremities, arms, and legs seem very common.
They are. And the source is quite specific here. Injuries to the major arteries, subclavian near the collarbone, axillary in the armpit, brachial in the upper arm, the main femoral arteries in the thigh, and the popliteal artery behind the knee, these almost always need surgical repair if possible.
Okay. What about further down, like in the forearm or lower leg?
For the radial and ulnar arteries in the forearm or the tibial arteries in the lower leg, repair might depend on whether the other main vessel is working okay. If one is fine, sometimes the injured one can be tied off. But if both are damaged, or if it's the dominant vessel, you'd try to repair it.
And the source mentions a critical time frame for limb injuries.
Yes, this is really key. Advanced ischemia, severe tissue damage from lack of blood flow can start setting in within just 6 to 8 hours after an artery is blocked or disrupted.
Wow, only 6 to 8 hours. That just reinforces the urgency we talked about with hard signs.
Absolutely. Time is muscle, time is nerve, time is limb.
Okay, what about injuries inside the body? Abdominal vascular injuries.
These are often associated with damage to other organs, which complicates things significantly. And the source points out that injuries to the major vessels in the abdominal aorta and the inferior vena cava have very high mortality rates. We're talking 50–70% for the aorta, 30–50% for the IVC. Really dangerous injury.
How are those repaired?
Techniques vary. Sometimes direct suture repair, anastomosis, sometimes using grafts, either synthetic tubes or the patient's own vein to bridge a gap. Sometimes complex maneuvers are needed depending on what else is injured, like if the spleen's blood supply is damaged, the spleen might need to be removed.
Moving up to the neck carotid artery injuries, the source gives a specific approach based on the patient's brain function you mentioned.
Right. It's a critical decision point. If the patient already has a severe neurological deficit, meaning significant brain damage, likely from lack of blood flow before they got to surgery, the source suggests the artery might just be tied off, ligated. The risk of reperfusion injury, more damage when blood flow returns, might be too high.
But if their neurological status is okay,
then repair is usually considered safe and is recommended. Techniques can range from sewing the vessel directly, maybe using a patch of vein or synthetic material to widen the repair, sometimes using a piece of vein as a bypass graft, or even endovascular options like stents or balloons in select cases.
and you have to think about the spine too.
Definitely. Neck trauma often involves potential C-spine injury, and monitoring blood flow to the brain during and after repair, maybe with transcranial Doppler, TCD, is important.
What about the other main neck artery, the vertebral artery?
Injuries there are relatively rare, often associated with other cervical injuries, maybe penetrating trauma or fractures near the spine. Exposure for surgery is difficult because of where they run.
If both the carotid and vertebral are injured, which one gets priority?
The source is clear. The carotid repair takes precedence. Maintaining flow through the carotid is generally more critical for brain perfusion,
Okay. Moving into the chest now, thoracic vascular trauma.
often caused by blunt force, like high-speed car accidents causing deceleration injuries to the aorta, but also penetrating injuries from knife or gunshot wounds.
And these can be immediately life-threatening.
Absolutely. Injuries here can cause things like a tension pneumothorax, collapsed lung filling with air, hemothorax filling with blood, or cardiac tamponade, blood filling the sac around the heart. These might require immediate treatment right in the emergency department, like inserting a chest tube or even performing an emergency thoracotomy, opening the chest to find and control the bleeding source.
A very high-stakes situation.
And extremely.
And finally, the source also covers injuries to veins. Are these managed differently?
Well, the principles are similar: control bleeding, restore flow if possible, especially for major veins. The source lists the common sites for major venous injury. The superficial femoral vein in the thigh is most common, followed by the popliteal vein behind the knee, and the common femoral vein higher up.
And repair techniques.
Similar to arteries, direct repair by sewing, endorphy, is preferred if possible. Sometimes grafts are needed. Those synthetic grafts don't work as well in veins as they do in arteries. Ligation, tying the vein off, is sometimes done, especially for smaller veins. But repairing major veins like the femoral or popliteal is generally preferred to prevent long-term swelling and complications in the leg.
So getting the immediate repair done is obviously a huge step, but the source really stresses that potential complications can arise down the line, even after successful initial management.
Absolutely. The recovery journey doesn't end when the patient leaves the OR or even the hospital. There are definitely things to watch out for.
Like blood clots.
Yes, deep vein thrombosis, DVT, is a major concern in trauma patients in general, due to immobility and the body's response to injury. The source notes a high incidence, maybe up to 50% developing DVTs, and while most don't cause immediate problems, there's a small but real risk, maybe 1% of a fatal pulmonary embolism, PE, where a clot travels to the lungs.
So prevention is key.
Definitely. Things like compression stockings, medications, anticoagulation when safe, and sometimes IVC filters little baskets placed in the main vein leading to the heart to catch clots are used, especially in high-risk patients who can't be anticoagulated.
Another potential issue you mentioned is a pseudoaneurysm, sometimes called a false aneurysm. What's that exactly?
It's basically a contained rupture of an artery. The wall tears, blood leaks out, but it's held in by the surrounding tissue, forming a pulsating sac of blood connected to the artery. The source notes these are relatively common after procedures like catheterization, but they can also develop more subtly after trauma, sometimes days or weeks later.
How are they found?
Ultrasound is very good at detecting them. It can easily differentiate a pseudoaneurysm, which will have blood flow within it, from just a simple hematoma or bruise. Repair usually involves surgery to close the hole in the vessel wall, sometimes using a patch.
Okay. And an arteriovenous fistula, that's the abnormal connection between an artery and a vein.
Right. These also often present late after the initial injury. The high pressure from the artery flows directly into the low pressure vein. Patients might notice swelling, prominent veins, or sometimes feel that vibration, the thrill, or a doctor might hear a continuous whooshing sound, a bruit over the area.
And repair involves
Surgically separating the artery and vein or repairing the holes in each vessel.
the source also links something called thoracic outlet syndrome to a history of trauma.
Yes, in many cases. This involves compression of the nerves or blood vessels in the space between the collarbone and the first rib. An old clavicle fracture, for instance, can put the subclavian vein at risk, potentially leading to clots, thrombosis, in that vein.
Now, a really significant complication highlighted in the text is nerve injury.
Hugely significant. The source notes this is very common alongside vascular injuries, especially in the limbs, affecting maybe half of patients with upper extremity vascular trauma and maybe a quarter in the lower extremity.
And the critical point is
That the nerve injury often dictates the long-term functional outcome of the limb, sometimes even more than the vascular injury itself. You can fix the artery, get blood flow back, but if the nerve controlling the muscles or sensation is permanently damaged, the limb might not work properly.
can nerves be repaired immediately?
Immediate repair in the setting of major trauma is rare and technically difficult. Sometimes it's attempted later, but in cases of severe combined nerve, bone and vascular injury, the source notes that early amputation might unfortunately be considered the most realistic option to allow for better prosthetic fitting and overall function later on. A very tough decision.
Wow. Another serious one mentioned is compartment syndrome. You hear about this sometimes with crush injuries.
Yes, it's most common in the lower leg, particularly the anterior compartment. It's a dangerous buildup of pressure within the tight muscle compartments, usually from swelling or bleeding after trauma. This pressure can squeeze off blood flow within the compartment, damaging muscles and nerves.
Can it happen later too?
Yes, it can be acute right after the injury, or it can be a delayed response after blood flow is restored to a limb that was ischemic for a while. That's reperfusion injury causing swelling. Early recognition is absolutely vital to prevent permanent damage or even limb loss.
How is it treated?
If the pressure inside the compartment gets too high, the source mentions a threshold of over 30 mmHg, then urgent surgery called a fasciotomy is needed. That involves cutting open the tough tissue surrounding the muscle compartments to relieve the pressure.
And finally, the text mentions secondary lymphedema.
Yeah, that's swelling caused by damage to the lymphatic system, which drains fluid from tissues. It can happen with extensive tissue loss, like degloving injuries where skin and soft tissue are torn away, potentially damaging lymph nodes and vessels.
So it's clear the picture isn't just about fixing the vessel itself. It's managing this whole cascade of potential downstream effects and associated injuries.
Exactly. It's complex, long-term management often.
The source also covers the vital role of nursing care in this really intense environment. It highlights how crucial astute nursing assessment and management skills are.
Absolutely critical. Trauma bays, ICUs, they're fast-paced, complex environments. Identifying subtle signs of vascular injury amidst maybe multiple other life-threatening problems requires real vigilance and expertise.
Teamwork sounds essential.
Totally. The source correctly points out that assessment and management of the vascular injury often have to happen concurrently at the same time as addressing other major injuries like head trauma, chest injuries, abdominal bleeding. The whole trauma team has to work together seamlessly.
And the source lists specific clinical features nurses are looking for that might suggest involvement of the big vessels near the heart, the great vessels.
Yes, things like unexplained cardiac arrest, profound shock that's hard to reverse, signs of cardiac tamponade, a widened mediastinum seen on chest x-ray, or large or recurring blood loss from a chest tube. These raise suspicion for major thoracic vascular injury.
What are some key nursing interventions mentioned?
Well, beyond the basic resuscitation, ACLS protocols, it's things like continuous, meticulous neurovascular assessment of any injured limb, checking pulses, color, temperature, sensation, movement, managing fluids and blood transfusions carefully, preparing the patient rapidly and safely for the operating room if needed, keeping the patient warm, pain management, communicating effectively with the whole team.
And what about patient outcomes overall?
The text indicates that, compared to some other severe injuries, the overall mortality rate specifically from vascular trauma itself is relatively low, maybe around 5%, according to one source mentioned. But the final outcome, survival, limb salvage, long-term function, is heavily influenced by a lot of factors.
Like
How quickly the injury was identified and managed initially. The extent and location of the injury area is worse than a forearm artery, obviously. The time it took to get blood flow restored, the patient's age and underlying health status, how well they're managed after the procedure, and whether complications like shock, sepsis, or major infection develop.
Okay, so beyond the immediate hospital stay, the source talks about what's important for patients and their families to know for care at home and recovery.
Yeah, patient teaching is huge. Monitoring for potential issues after leaving the hospital is key. Things like signs of graft infection or problems with wound healing.
They need very clear instructions.
Absolutely. Specific instructions on wound care, hygiene, what signs and symptoms might mean a complication is developing, like increasing pain, swelling, redness, fever, numbness, or weakness. Also, pain management strategies, the importance of participating in physical therapy or rehab.
And follow-up is crucial too.
Essential. Making sure they have access to the vascular team for follow-up appointments, which, as the source notes, can be a challenge if the patient lives far away from the trauma center.
Understanding the long-term picture.
Yes, understanding the potential long-term effects of their specific injury, and the importance of sticking with follow-up checks, especially if they had endovascular procedures like stents, which might need periodic imaging down the road to make sure they're still working properly. The source also briefly touches on the ethical context surrounding trauma care, things like family presence during resuscitation, organ donation considerations, supporting grieving families, and managing the stress on the care team itself. Important dimensions.
This has been a lot of really complex information. We've gone from how these injuries happen to how they're spotted, how they're fixed, and all the challenges that can come afterward.
It really covers the waterfront, drawing directly from the material you provided. The mechanisms penetrating, blunt, iatrogenic, the key signs like hard versus soft, the absolute urgency involved, the different surgical approaches depending on location, and that whole list of potential complications.
To really bring it all together, the source includes a case study, which I found incredibly helpful. Let's maybe walk through that as a concrete example of everything we've been discussing.
Yeah, case studies are great for that. So the patient described is an 18-year-old male. He suffered multiple small caliber gunshot wounds, abdomen, extremities, chest, found unconscious.
His initial presentation sounds like a textbook example of severe trauma. Unresponsive, low blood pressure, really fast heart rate, struggling to breathe.
Classic signs of shock and serious injury.
And the physical exam found that large hematoma in his right thigh that was visibly getting bigger. That's a clear, hard sign of vascular injury we talked about.
Exactly. An expanding hematoma is a hard sign.
And crucially, the pulses in his right foot were absent.
Right. Absent pulses in a limb after trauma like that, major red flag for arterial injury.
Investigations then showed several injuries. A collapsed lung, signs of injury inside his abdomen.
Yeah, free air, bullet fragments on imaging.
And importantly, specialized imaging of his right leg vessels, an MRA, it says, showed a major disruption or tear in his right femoral artery. Toxicology also came back positive for alcohol and marijuana.
So multiple serious injuries confirmed.
He was immediately given IV fluids. His blood pressure improved somewhat. The major injuries needing urgent surgery were identified. Bowel and spleen damage, the collapsed lung, and that devastating vascular injury in his right thigh.
He went straight to the operating room. The source details what they found and did. He needed parts of his bowel removed, his spleen removed.
A splenectomy and sigmoid colectomy?
Right. A chest tube was placed for the lung. And for the key vascular injury in his leg, they performed a bypass graft. Specifically, it says a fempop bypass using an in situ vein, meaning they used one of his own leg veins, left in place but rerouted, to bridge the damaged section of the femoral artery down towards the popliteal artery behind the knee.
That directly illustrates the kind of surgical management we discussed using a bypass graft for a major limb artery injury.
Exactly, a standard and effective technique.
Then the nursing management described highlights that critical post-op monitoring, transferred to the SICU, still intubated.
And the absolute focus was on ensuring his leg was getting adequate blood flow after that bypass.
And the key update from his clinical course:
peripheral pulses returned to his right foot. His leg became warm, color was normal, his neurovascular status, sensation, and movement was stable. This is the confirmation that the bypass graft was working successfully. Huge relief for everyone involved.
The rest of his hospital stay sounds like, well, standard recovery from major multi-system trauma. Weaned off the ventilator, pain managed, digestive system started working again, eventually up and walking.
And remarkably, he was discharged home relatively quickly, after just 5 days.
With a plan for follow-up, of course.
Yes. But what's particularly impactful about this case study, and something the source makes sure to include right at the end, is the social history.
Right. It mentions he was reportedly shot by a rival gang member over a drug deal.
That adds a whole other really sobering layer to the clinical picture, doesn't it?
It really does. And the conclusion notes that despite the severity of the injuries sustained in this incredibly violent context, he actually made a full physical recovery. And with family support, he was planning to enter rehab and counseling, trying to leave the gang life behind and return to school.
This case study just ties everything together so well. You see the violent mechanism, the urgent assessment using those key hard signs, the confirmation with imaging, the complex surgery addressing multiple life-threatening injuries, including the vascular repair.
Then the critical post-op care ensuring the bypass worked.
And finally, that glimpse into the challenging path towards not just physical recovery, but social recovery too.
Wow.
Trying to change the circumstances that led to the injury in the first place.
It really shows the whole arc of a vascular trauma patient, start to finish and beyond. So, okay. We've covered the breadth of this topic, drawing heavily on your source material. The sheer urgency, the different ways these injuries happen, accidents, medical procedures, violence.
How they're recognized through careful assessment, those hard versus soft signs and advanced imaging. The complex world of surgical repair and ongoing management, the many complications to watch out for.
And the critical role of the entire healthcare team, all culminating in that really powerful case study.
And hopefully, Understanding all these elements, recognizing the signs, appreciating the speed and complexity of the care required, and seeing the factors beyond just the physical injury itself, like risk factors and the circumstances surrounding the trauma, gives you, the listener, a truly well-informed perspective on this vital area in medicine.
Absolutely. So as we wrap up this deep dive, we've gone from that stark statistic about trauma's impact right down to the nitty-gritty of recognizing and managing these often devastating vascular injuries. We've seen the different faces of this trauma.
And walk through the complex steps required to save limbs and lives, and the potential challenges that follow recovery.
And that case study, wow, it serves as such a powerful reminder that the journey isn't just medical, is it? It's often deeply intertwined with the social context, the choices, the environment surrounding the injury itself.
It really is a crucial dimension.
Which leaves us with maybe a final thought for you to ponder. How does the specific context of an injury, whether it's, say, a fall in an elderly patient leading to iatrogenic injury, a car crash, or an act of violence like in the case study, how might that context influence not just the immediate decisions made by the medical team, but the patient's entire path to recovery? Does it impact their long-term health outcomes, their life choices, their interaction with the healthcare system?
It adds a layer of complexity to trauma care that goes way beyond just the technical fix, doesn't it? Something powerfully illustrated in the material we explored today.
A crucial dimension to consider indeed. We really hope this deep dive into your source material on vascular trauma has been valuable and insightful for you. Keep that curiosity going.
Absolutely. Until the next deep dive.